The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The broadcast is now starting. All attendees are in listen-only mode.
Commissioner Deckett, we'll get going here in just a few minutes, sir.
Thank you. Am I the only virtual attendee this morning or this afternoon?
All right, good afternoon. It is 1:32. I am going to call this December 12th HCC meeting to order. First item of business will be to take roll. I know we have one commissioner that will be absent, one that is on the way, and one we are trying to get on virtually. But in the interest of time, we'll go ahead and get started. So we'll take roll. Commissioner Deckent,
Present.
Commissioner Kane,
Present.
Commissioner Schmidt,
Here.
Commissioner Landwehr. I think she's trying to get connected. We'll circle back on that. Commissioner McGinn is not in the room. Commissioner Hensley, I don't believe is online either. And chair is present. So we've got a quorum to go ahead and get started. All right, very good. Committee, I sent an email the other day, but just to state it on the public record as well, I do have a hard stop at 3 o'clock today. So we will, of course, allow plenty of time for discussion and all the agenda items, but we will have a hard stop at 3 o'clock. So if time runs out on us, we'll make sure that we pick agenda topics back up at the next meeting, or if we need to, we can schedule a special meeting, assuming council is okay with that. First item is to approve the August 22nd minutes. Those were sent the other day. So before we have a motion, any revisions to those? Hearing none, I would entertain a motion.
This is Steve Deckett. I move the minutes be approved as presented.
Okay, there's a motion. Do we have a second?
I'll second. This is Commissioner Kane.
Commissioner Kane. All those in favor?
Aye.
Any opposed? Motion carries. Minutes are approved. All righty. Do we have Commissioner Landwehr online yet? Okay. If you can just keep an eye out for me. And then Commissioner Deckent, just so you know, I do not have a laptop in front of me. So once we get into discussion, if you need something, please just jump right in and let us know, and we'll make sure we recognize you. All right, Commission, we are going to move on to agenda item number 2. This is an action item. Director Flory is going to review the audit services contract. So, Director?
Okay. I'm being advised that they asked that you have votes done by a roll call so that it is official. Is that correct?
Okay.
Oh, the chair needs to vote.
Chair votes aye. I approve of the minutes. Thank you.
All right.
Thank you for keeping me honest.
All right. So our audit services contract went out for a bid. The audit vendor, they work on our self-funded plans, which are our medical insurance, dental, and prescription drug. The purpose of these audits are to ensure that our vendors are following the contracts and adhering to the requirements, paying claims according to the benefits as they are written. Our auditors go in, they review the plan documents to ensure that they're clear. They review the internal controls that the vendors have in place to make sure that claims are being processed accurately and correctly, and that payments are being made accordingly. So the vendor that currently provides these services to us is Sagebrush. In our contract with Sagebrush, they are currently doing the self-funded plans, as well as we have a dependent eligibility verification audit where we ask particularly about spouses and stepchildren, since we already have verification documents on all of our employees with their children. We get birth certificates before we put them on coverage. This is just to verify the member's still married, there hasn't been a divorce, that we're covering the right people. We also do an audit on the premium collection, and this goes back a couple years where we had questions about whether with all of our different groups that all of the premium dollars were coming in correctly, because we deal with multiple payroll systems within the state system as well as our non-state groups. So the vendor does a review to make sure that if we're covering 5 members with a particular group, that we're getting payment for all 5 members. We also have within our audit contract pre and post audit capabilities. This is something we haven't used because this is generally something we would use if we were moving to a new vendor to make sure, or if we were changing benefits dramatically, to make sure that the vendors are accurately paying claims according to the contract. This is something that we added to our audit contract a number of years ago after we had a first round of medical audits with a new vendor and found that they had not set up the benefits correctly in accordance with our benefit descriptions. So those are kind of the services that we look at with our audit contract. And Pete, we can go forward. I should have said that. Sorry about that. So again, this just goes over again some of the services that we receive from our auditors as they go in and review our contracts for us. Again, on the next slide, it says that Sagebrush is our current incumbent. They were first issued a contract in 2021. It is a 3-year bid, so this is our standard period to go out for a new RFP. On the next slide, we have our 2 bids that we received. We received one from Myers and Stauffer, and the other came from Sagebrush. We held finalist meetings with both vendors. Our RFP outlined all of the services that we were requesting from the vendors so that they knew exactly what services we were wanting. On the next slide, we review the bid evaluations. We are looking for in a vendor is experience in performing claims audits, being knowledgeable about doing audits. Of course, we look at the costs, their experience in reviewing a transparent pharmacy arrangement that like the one that we have. That's a little different from what some other vendors do. We make sure that they have experience doing a dependent eligibility verification audit, better known as a DEVA, and that they have experience with medical and dental plan audits. On the next slide, again, this just outlines the services we were requesting within this RFP. We had the 3 audits, the medical, dental, and pharmacy audit, the DEVA audit, the premium recon audit, and we do have the option of a pre and post audit, should that be appropriate. So next we're going to look at the costs that were bid for these services. We've split them out here to show you what the individual audits cost, and to the far right-hand side, you'll see what we currently are paying for those services. The vendors do bid them as a unit, so they know what services we're asking for within the scope of each one of these audits, and they give us a price for that audit for each time it's done. So we have years 2024, 25, and 26. So this is the medical and dental costs. On the next slide, we have the pharmacy audit cost. Again, showing on the right is our current price and then what was bid by the 2 vendors. We will have a summary slide in the back that shows you all the audits put together. On the next slide, we have the dependent eligibility and premium recon audits, the cost for providing those. And then on the final, next we have the pre and post implementation audit cost. Just to give you an idea of what the vendors would propose to charge. Again, this is an optional audit. It's one we only do if we need it. Otherwise, we do not. And then finally, on the next slide, we do have the summary that shows you in total a comparison of the charges between the 2 vendors. Myers and Stauffer is on the top, and Sagebrush Analytics, our current vendor, is listed on the bottom. And with that, I'm open to questions.
Very good. Thank you, Director Flory. Appreciate the overview and the review of the information. Also want to make sure that we reflect in the minutes that Commissioners McGinn and Hensley are both present. With that, any questions for staff? Commissioner Schmidt.
Thank you, Mr. Chairman. Can you point to what may have caused the pharmacy to go up so much more than the rest of the services, the audit services?
I think as Sagebrush and Myers and Stauffer looked at the bid specs, we tried to be more specific about the services that we were requesting because we require some things that are not typical. For example, part of our audit requires the vendor to send out letters to a select number of independent or chain pharmacies in Kansas and verify the payment against what the PBM says the vendor received, just to verify that there is no spread. And that's a little different than what other audits typically do, but it is something that we need to do. So it causes our audit to maybe be a little more expensive. And as they've more skilled, this was their first time going through, they may have decided that that costs more than they thought it might.
So the RFP requested more services this time than it did 3 years ago?
I think we were just more clear on the services that we requested. Based upon the questions that we received from vendors during the course of the process, I think we were just a little more clear about our expectations about what they would do in the pharmacy audit than maybe we had been in the prior time.
And then a second follow-up question is on page 18 on the premium reconciliation audit. Is that something that SCHP staff could do? It does. Do you have staff members that could do that audit?
It's a very complicated and time-consuming audit, and right now our staff does not probably have the amount of time that would be necessary to do that. It involves, they get a record of an eligibility file and they get the premium file, and they have to do a series of reconciliations to make sure that for each one of the units that we're getting all of the payments for all of the individuals. So it is a very time-consuming and complex audit. Each one of the universities has their own payroll system, so we're dealing with multiple files. So at this time, if we did something scaled down, we could probably do that in-house, but to do what they're doing, I don't know that we could take that on without additional staffing.
Finally, do you know, like from working with Siegel, do other large employers, do they do hire auditing firms to do this, like Sagebrush, to do these type of audits, self-funded, other self-funded plans?
Siegel, if you would like to say that, I would say my experience is that in discussions with the legislative post audit over the course of the years, they have been very committed to us doing audits of our self-funded plans to ensure that payments are accurate. That's one of the messages we've heard from them very clearly, but I'll let Ken or Patrick speak to Siegel's experience in the self-funded world.
Sorry, Ken, if I can have you come to the microphone and make sure you state your name and who you're with.
Here with Siegel. Right. Okay. Yeah, larger self-funded plans always do audits as part of their contracts. Not necessarily like a DEVA audit. Is sometimes once in a while they do those, so depending on eligibility, like to do a cross check on their systems and procedures and all that stuff. But that's really not like every single time. Sometimes, but premium rec, it depends on the client, but pretty much the pre and post implementations though, for when you do a big procurement and there's like if you change vendors or something, you want to do those.
We're getting quite a bit of background noise from somebody who's coming off of mute, so I'm not sure if all those who are online, if you can mute yourselves, that would be helpful, unless Commissioner Deckent, that's you, in which case we'll need to find a different avenue to ask questions. Commissioners, any other questions? I've got a clarifying question. So the proposal in front of us is to approve, the request would be to approve one of the two proposals, and it would be for the 3-year time frame, right?
That's correct.
Okay, thank you. All right, commissioners, I would entertain a motion if anybody has one.
This is Steve Decken. I move that we award the audit contract to Sagebrush Analytic.
Okay, you've heard the motion. Is there a second? Second by Commissioner Hensley. Discussion. Any discussion? None. We'll go ahead and do roll call. Commissioner Deckent?
Aye.
Commissioner Kane?
Aye.
Commissioner Schmidt?
Aye.
Commissioner McGinn?
Aye.
Commissioner Hensley?
Aye.
Chair votes aye. Motion carries. All right. It would appear as though the commission is in a holiday treat hangover right now. It's not as chatty as we normally are. So I must have struck fear with the 3 o'clock hard deadline. All right, Commission, that takes care of our action items. We're going to move on to the report section of our meeting. We're going to start with agenda topic 3, which is a financial report from Siegel. So Patrick, if you can come up and please introduce yourself to the committee or the commission.
Patrick Klein with Siegel.
Take us away.
All right. Can we move to the? Oh, okay. All right. You're gonna make me work today up here. All right. All right. So the first page financial report, we've got our actual data through October, comparing that to the budget in the table on that first page. You can see that our initial reserve balance was projected to be 77.8 million, and it came in at 77.2. So only 0.6 million off from our initial budget, and we've got $438 million flowing in and out of the funds year to date. So that's pretty close. We're right on track through October. We had data through July in the last report, and we were showing a $2 million gain. So the direction has changed, and we've gotten closer to our initial budget, but it's a small loss instead of a small gain from last time. Okay. All right. Oh, before I leave real quick. So you can see the revenue's up 2%, and so are the expenses. This is largely driven because you've got more enrollment than we had at the beginning of the year. So 1.2% higher on active in COBRA, 422 people in total. And we have our snapshot of the October contracts. Plan A still has the bulk of the membership. Plan C is not too far behind, and then fewer people in J and N. All right, so here's our multi-year projection. We're projecting 23 to end at 70.2 million. Originally, we were at 72, so 1.8% delta. That's 0.3% when you factor in the total program expenses. The different components of the projection have stayed relatively consistent, except for medical. We've seen kind of a sharp increase since the last time we presented. It seems to be due to large claims activity. So we did bring this table in to show you a comparison year to date. So through November 15th, the number of large claims over 100 million, and then the amount. So you can see that, 100,000, sorry. So yeah, you can see that 2023 is a bit of an outlier here with the 67.8 and 318 claims. So that's really driving this medical being higher than our trend assumption. We also have a few things to note on the admin expenses. We saw a gain on the Marathon on-site clinic versus the initial projection. And then there's a few contracts that are now being paid under the administrative fund. So the RX Savings, CompSite, and Gainwell used to be in that contract fees other bucket, and now they've been moved to the administrative fund. Any questions on any of the information so far? No. All right, so with all the information that I provided before, that all rolls into this calculated funding for future years, and we're at 6.2%. That's up from the 4.6% from last version. And then we have our sensitivity chart. This is the same thing you've seen in the past, 2% higher or lower trend. I don't want to spend a lot of time here, but we did add another table that shows the funding sensitivity. So that 6.2, how that changes when you get $1 million worth of adverse claims or favorable claims in the experience period. So you can see basically $1 million in claims is worth 0.5% roughly, and how that impacts that percentage. And a lot of that is, you're locked into 2025 right now. So you really only have 26 and 27 to spread that out. And then once we add a year next projection, that'll make the model a little less sensitive, but just wanted to add that for context. That's all I had planned. Are there any questions?
Thank you, Patrick. Just for clarity, on page 30, the table you have there at the bottom, so that is to say that $1 million either way outside of the projection. So if we had claims in excess of what was projected to the tune of $1 million, that's a 0.5% increase in the 26 and 27 projected rate increase, correct?
Right.
Okay. All right, thank you. Commissioners, any questions? Commissioner Decken, do you have any questions?
No, I do not.
Okay, very good. Commissioner Schmidt?
Thank you, Mr. Chairman. I'm not sure if this is the exact point to ask this question. It doesn't really involve seagulls, so I'm not really sure. But since you brought up Marathon, I had received information about a state employee that, you know, I know we continue to say that Marathon is not a walk-in clinic, but yet, you know, we send our employees there when they need something on the day of. And this particular employee was not an employee of mine, just for the record, but worked in the downtown complex and was feeling pretty rough and had a lot of abdominal pain and showed up at the clinic on a Tuesday and was told that the first available appointment was on a Thursday afternoon. And so he decided that he was not well enough to continue to work, and so decided to drive back to Kansas City and called his own primary physician on the way in and into Kansas City, and the doc said, don't even stop at my office, just go to the ER. Long story short, he had an appendectomy that afternoon, and you know, I mean, he would have been in pretty bad shape by the time Thursday came along. Can we get some statistics from Marathon on like how many people walk in the day and cannot get an appointment within, you know, 12 to 24 hours or that day, and how, I mean, what does that look like? I mean, are they understaffed? Are they was it just the timing of the event? I mean, I would like to be able to know what that looks like.
Very good. Appreciate the question and the story there. And first of all, I'm thankful the employee had the wherewithal to call their PCP and get to the hospital, make sure they're safe. We can have staff work with Marathon to see what the statistics are for number of employees that visit in a day. I don't know that we'll be able to get to those turned away unless they do track that. We might be able to get to filled slots and how quickly. And I suspect we'll need to do this on maybe a monthly and or weekly basis. Obviously, the time of the year is going to determine the demand for services. So
we can get some additional information on utilization. I know that we have a full-time mental health provider, and that person is currently booked at capacity, and we have a wait list. We do encourage members that need additional mental health services that can't get in person to use the Anywhere program, because we have additional access through Anywhere to get additional mental health services to members needing those if they can't get into the provider. But we can certainly come back with some information about, I don't know if they'll have exact information on how many people, how quickly they could get an appointment, but we'll go back and see what information is available, and we'll certainly bring the information back to you.
And I'll make sure I'll also commit to the commission here that I'll sit down with Director Flory, and she and I can sketch something out in terms of what we think would be useful for the commission, and we can bring it back as a first pass. And if there's more information that's needed, we'd be happy to go back for that as well. So, Commissioner McGinn.
Thank you, Mr. Chair. You brought up the mental health, and we had this conversation about 6 months ago, and I was just curious, as you look, we talked about is that their mental health provider year round, or because I think we thought that it was more like maybe you'll get 4 to 6 sessions and then you'll be encouraged to go somewhere else. Otherwise, we need to add another mental health person.
Yeah. At this time, we have a full-time person. I think back when we were talking about that, we had 2 part-time people that were splitting the role. One was in person and one was remote. And since that time, we have gone to a full-time person in-house and then added the Anywhere program to enhance the access statewide. I don't know the answer to how many sessions. Again, that is something we can certainly dig deeper into with Marathon, because I know the discussion that we had recently in-house was about that exact same question. Are they seeing the same person for an extended period, or is it that there are multiple turnover of individuals coming in for 4 to 6 sessions? So we will certainly dig into that, and as part of our commitment to bring information back, we'll bring more back to you on that. Thank you.
Commissioner Kane.
Director Flory, could you provide more information about the Anywhere program, such as what services they provide? How is it accessed?
Sure. All you
Thank
have
you.
to do is call the health center phone number, and it will put you into what they call MRT, and they will talk to you and find out what it is. And, first of all, they're going to ask if you're in this big area, are you wanting to book with the Marathon Clinic itself? But it is available to employees statewide, and they have mental health services and pretty much anything that you could do through a telehealth or a video visit. You can do through Anywhere. So it's both medical services. If you are a member who maybe is looking to get biometrics done, you can contact the Anywhere program. They'll put you in contact with a physician who can order your labs at a local lab. We utilize our preferred lab program for that, which is Quest, the University of Kansas Health Systems, and Stormont Vail Labs. So individuals can contact the Anywhere program if they want to get their biometrics done. They can contact them if they want to talk to a physician about, a rash, or really anything that you could use a telehealth service for, you can use Anywhere for. Obviously there are some limitations because, you can't really check blood pressure remotely, but it is available for other types of healthcare services a member might want to access that they can access remotely or using video visits.
Thank you.
Very good. Any other questions from any other commissioners? Seeing none, thank you for the report. Certainly appreciate that. And Commission, we are going to move on to tab 4 in your books, the open enrollment report. Director Flory is going to walk us through that. Full disclosure, we did not yet have the full report ready just yet. We will have that hopefully in the next couple of weeks, but she's going to provide some high-level insights as to what happened during open enrollment.
Okay, so as the secretary said, these are initial numbers. We will bring you back the full suite of information like we did last year in February and go through it in detail. So as kind of the beginning of our discussion about plan year 2025, we'll go into greater detail about where individuals landed within the open enrollment. As you can see from the chart, we saw an increase in members enrolling in medical, dental, vision. Our voluntary programs, this year we did move those to Metropolitan Life, and we saw an increase in enrollment in the accidental insurance, critical illness, and hospital indemnity. Again, flexible spending accounts, we saw a slight decrease in the number of members taking the mass transit FSA. As you'll recall, this was the brand new FSA we put in last year that is for individuals who are like riding in a van pool. It is limited by IRS rules as to how you can use that commuter benefit to pay for services. The parking did see an increase in enrollment, and we did see an increase in the dependent care and health care FSAs. Again, those are ways for employees to set aside funds out of their paycheck pre-tax and then use them for IRS approved expenses for health care if they're on plan A or plan J. And then if they're on plan C and N, they have a limited purpose that they can use for dental or for vision because they have if they have the HSA, they cannot have a full-blown FSA with that HSA. Now, if they take the HRA, then they could have a full-blown FSA. We also saw some slight decreases in the number of individuals taking a single HSA or a single family or a family health savings account. Again, these numbers are preliminary. They may shift slightly as we work through all of the details of open enrollment, and we will bring you back the greater detail in February that shows where folks have landed.
Very good. Thank you, Director. We'll open up to questions. Commissioner McGinn.
Thank you, Mr. Chairman. It seems, I don't think it was August. I think it was the time before that. I asked a question about Delta Dental's orthodontic type work. And seems like it's been $1,000 for a number of years. And I shared that it seems like there are more people that are doing orthodontic work or wanting to have that done. And I believe you said you were going to check to find out why that's frozen in time. And
Yes, we did. And I think it was in the follow-ups that we did at the August meeting. In the appendix, we provided some additional information. We found that most of Delta Dental, we asked them for additional feedback, and they said that most of their large employers have an annual benefit maximum of $1,500 to $2,500 and an orthodontic lifetime benefit maximum of either $1,500 or $2,000. So that's something that, as you're thinking about plan year 2025, you know, that certainly is something that we could discuss further.
Because we're 1,000. Right, and so
yes,
you're saying the market out there is 1,500 to 2,000, or
yes, for large employers
okay.
like us, it's 1,500 to 2,000. One difference with our one caveat on our benefit maximum to keep in mind is a lot of employers include preventative care, the cost of that, into the benefit cap, the overall benefit cap for the year, and we do not. We promote preventative care. Getting our employees in to get those dental services is really important to their overall health. And so the cap on the dental program does not apply to your two preventative screenings that you get covered in full. It's for any of the restorative work that you would have. So that's a little bit different nuance than maybe what other large employers have.
Thank you.
And to piggyback on that, do we have, and maybe it's been forever, but do we have how long we've been at $1,000 for annual benefit for orthodontia?
Yeah,
Forever.
I would say
Okay.
as long as I can remember in the health plan when we've had orthodontic benefits, I think it's always been 1,000. I don't think it's ever been increased. We did, in the information we provided in August, the cost impact to increase the dental orthodontic maximum to go to 1,200 would be approximately a 1% increase in overall claims. To go to 1,500, it's about a 2.5% increase. They're estimating to go to the full $2,000 would be potentially a 5% increase in claims.
Commissioner Schmidt.
I ask a question about that, but now I have a question. So is if you get your retainer replaced, is that an orthodontic benefit? Or is that after you've come out of the braces or whatever your Invisaligns, whatever it is that straightened your teeth, and you're in the, do the replacement retainers and things, does that go into the orthodontia benefit, or does that back into the dental?
I believe it would be orthodontics, but to be clear, let me take it back and just verify that with Delta Dental, but I believe it falls in under orthodontics, but let's clarify it and we'll bring it back as a follow-up.
Okay.
Commission, why don't we add orthodontia benefits as an agenda topic to the February meeting? We'll get a little bit more information. We can dust off the analysis that was done for the August meeting and try to refresh that. It sounds like there's great interest in that, so let's not wait till the August meeting. Commissioner Decken, did you have a question?
Yes, I do.
Go ahead.
Jennifer, if you could, or have you speculated, this is the first year in several, at least, maybe 5 or more, that we've had increases like this in terms of enrollment. Any thoughts on what's brought that about?
Well, you had asked us that question at the last meeting, and in the appendix to this meeting, which if I can find my way, there's going to be Appendix B. We went back and looked at some of the information about where the increases in employment were occurring. I know it's, excuse me, 56. Okay, page 56.
Okay.
We found that we had a couple of new non-state groups. So our top 10 employers with increasing enrollment, number one was KU Med Center. They've increased their enrollment by 208. KU, Wichita State also have seen increases of 182 and 127. Southeast Kansas Mental Health Center is a new non-state group, as is Thomas County. And so those are new employees that we're showing. We're also showing that KDOT, Health and Environment, K-State, and the Department of Revenue and Lansing Correctional all have had some increases in employees.
Just doing a quick math, that comes pretty close, those numbers alone, then to the increase in enrollment. Is that an accurate addition real fast on my part?
I believe so. Those were the top 10 groups
Okay.
that had increases in employment.
I would assume they're more than the number that was added, and then you have some drops as well. So it's going to net out to the end. But yes,
Yeah.
this is the lion's share of what's on there.
Yes.
Well, I did see that. I apologize for not recognizing that was the response you put together to my having asked that. So I thank you. I guess certainly the good on that is for those employers, those state employers, and my background in corrections, it's certainly a tremendous thing and a positive to see that kind of increase in employment. I know in corrections they're hurting terribly. And so I would hope that at KUMC and the others as well, that's a matter of their filling positions they've been struggling to fill for some time.
All right. Commissioner Schmidt.
Thank you. Well, as a follow-up to that, I guess I want to make sure that what Commissioner DeCant just said is the right interpretation. So is it due to an increased number of employees, or is it due to an increased uptake in current employees that now have insurance? Do we know that?
I don't know that we know why there's a difference. We just know that they have an increase in the enrollment in those universities, except for we know the mental health agency was new to us and the Thomas County was new to us. So those were new groups with new employees coming to us. But the others we assume they are new employees that have decided to enroll, since it would have been a mid-year enrollment. But that is my assumption, because otherwise you wouldn't be allowed to enroll mid-year. Unless you had a qualifying event, I should say.
So those numbers are not for 2024 enrollment?
No, it was the period from January 1st through November 1st, 2023.
I see that on the bottom now. Okay.
Yeah.
All right. Okay. So those would be new employees. Okay. Thank you.
Commissioner Decken, did you have another question?
No, thank you.
Any other questions, Commission? All right, seeing none. We will move on to the next report. This will be on tab 5. I had asked Director Flory to put together a schedule of the upcoming RFPs that we'll need to take action on in 2024. So Director, if you can walk us through this, page 48 for us, that would be helpful, please.
Okay. We will be going out to bid this year for the Medicare Advantage plan. That currently is a contract that we have with Aetna. These contracts all in December 31st of 2024. So we will be going out to bid for the Med Advantage. Now with Medicare Advantage, because there's federal funding involved, that will be one that we will not be able to release until the summer, when the feds have put out the information to the vendors. So likely that will come to the August meeting. We also have Medicare supplement insurance today with Blue Cross and Blue Shield. We have a number of plan options for retirees, and we're estimating that one for August of 2024. If we can get it done sooner, we will do so. But that one, because it is a fully insured product and not dependent on federal funding, we may be able to get it to you sooner. COBRA administration, we've already sent that to you all for review, and that one has already been put out for bid and has closed. We are currently reviewing bids. We estimate bringing that into the February meeting. The health reimbursement account and health savings account administration, that is currently a contract which we have with MetLife. That contract has already been put out to bid. You all have already reviewed that. It's already closed and the bids have been received. We estimate we will be bringing that to you at the February meeting. The voluntary prescription eyewear coverage through Avisus, that voluntary plan, that insurance is going to be estimated to come out at the June meeting. We are working on the draft of that RFP at this time, and we'll be getting that to the commission hopefully sometime the first part of the year so we can get that one posted. Dental benefits, again, dental is a self-funded plan, so we are looking only for administrative services. That contract is currently with Delta Dental. That one is another one that we do have a draft already in works. Once we have finished work on it in-house, we will be pushing out to the commission, and we hope to bring that bid back to the commission by the June meeting. Actuarial and consulting, that is currently our partners at Siegel. And that bid is one that we will be working on, and likely that one will come to the August meeting because we do need to work on that one, and we've not yet started that one. So any questions on those?
Commissioner Schmidt.
Thank you, Mr. Chairman. Well, I can't help but remember the Avisus issues with provider network, and you know, if my memory is correct, they maxed out on the penalties before the contract even started because they had made some wild predictions of what they could contract with and weren't able to. So will this contract have more teeth in it on provider networks and more accountability?
We will be definitely asking them more questions about how their networks are developed, how they work, how they are in the rural areas, how they contract with both retail and with providers, as well as we will be reviewing the performance guarantees and making additional changes to those as well as a result of your feedback that you all had provided to us at last, it was in 2021 when this one went out. I actually went back and pulled some of the commission minutes and have forwarded that to the team and said, you know, this was some of the commission's concerns, so we need to make sure that we are addressing them in the RFP document.
So when, I know you're very good at circulating to the commission members before the RFP is out for our input and things, would it be possible to make a chart of some sort that tells us like what the current contract, what the parameters were for performance versus maybe what you're suggesting in this contract?
On performance guarantees, yes. On the actual, probably the technical questions section, no, because the red line just gets too ugly and at some point you just have to clear it. But on the performance guarantees, absolutely, we can do you a side by side.
And I just think in the performance, I mean, for me, the big issue was the network adequacy. So anything to do with network adequacy and the performance guarantees related to network adequacy are what I'm mostly interested in, because that was the majority of emails that that filled my inbox. Thank you.
Yep, we can do that.
Any other questions or comments from the commission? All right, thank you, Director. Looks like we'll have a full agenda throughout 2024, so it'll be something to look forward to. All right, Commission, moving on to topic 6, which is on tab 6 in your book. Just want to review the upcoming meeting schedule. The next meeting is scheduled for Friday, February 16th, 2024, from 9:30 to 11:30 in this room. I wanted to note that we did make a change to the April meeting. I will take full accountability for trying to schedule a meeting on the Monday following Easter, also during legislative session, so my apologies. We've received feedback. Feedback was received, and we've made adjustments. So we've moved that to Tuesday, April 9th, 2024 in the afternoon. For our legislative members, this will be the first Tuesday after first adjournment, so we should be safe there. For the balance of the year, we've got those scheduled. You can see the dates that we're targeting. We are going to try to stick to the schedule. I told you in January when I came on that we try to do a year at a time, and we're certainly trying to adhere to that. With that, I just want to note there are follow-up materials in the appendix, as Director Flory alluded to earlier. So I'd be happy to give the commission a moment to review those or to ask any questions if anybody read those during the pre-read session. And as we're flipping through pages, I just would want to note on page 57, this caught my eye for a number of reasons. This is the rate history for employer, employee, and non-Medicare retirees from 2010 to 24. So, you know, we made a bold decision at the August meeting to hold rates flat, or excuse me, contributions flat for the next 2 years, which I applaud the commission for. And I think you can see in here why, what we're trying to get back to. If you look at the 2016, 2017, 2018, 2019 period, we were stacking 30 mid to low 30 rate increases on top of each other. So a 36% increase 1 year, followed by 30% increase the next year, followed by 31% the next year, followed by 17% the next year. So this period that we're in now, where we're able to take advantage of the state's fiscal health and provide stability for our employees, has been crucial to play a little bit of catch up from where we were before. Commissioner Schmidt.
Thank you, Mr. Chairman. Back in the published audit section, and I believe it is, I don't have the page number, but it doesn't have a page number on it, but on the medical administration audit of Blue Cross Blue Shield of Kansas, calendar year 2022, and maybe that's, I was just wondering, do we do this on Aetna also, or is it just on Blue Cross, or does it alternate years, or I cannot remember.
We do both Aetna and Blue Cross and Blue Shield each year on the self-funded plans. The Aetna one, it posted today. So if you go out there today, you'll on the link on our website, you'll find the Aetna audit is now posted.
Any other questions or comments?
Yes, this is Steve Deckens.
Go ahead, sir.
On the rate history, 2 questions. In 2012, the employee increase, is that accurate, 44%? I don't recall ever being involved in that high of a rate increase, but maybe so, and my memory just isn't accurate for that.
So
and if you don't have an answer at the moment, just a follow-up at any point would be fine.
So Steve, if you'll recall that there was a period of time when the state had segmented the population into 3 different salary tiers.
Right.
And that was the year they got rid of the salary tiers. And so while it looks like there was a huge increase, actually, not everyone experienced that level of increase. It was as they brought those tiers back together because they hadn't kept the bands hadn't changed, and it had gotten so lopsided that actually the number of individuals in that employee only low tier was so small, but it did look like a big rate increase, but it had to do with how those rates were all brought back together to where we just have one rate regardless of the income of that particular member.
I do recall that time. So, okay. So the small number of people just skewed that percentage tremendously like that. And it wasn't a rate increase that was affecting dramatically that many people.
Yeah, and also keep in mind that the employee rate at that time was, I don't know, it was very low. It was $10 or something. It was, so while it looks like 44% looks really, really big, you have to remember that the dollars that were involved were very, very small at that time.
Okay. Second question I had, the lower right-hand corner of that chart, is that just simply referring to the percentage of folks in each of the plans?
No, you'll recall at the August meeting when we discussed reblending the rates for our non-Medicare retirees, that for our members on Plan A and Plan C, who were the ones that back in 2010 took the big rate increases, or no, I'm sorry, 2015 and 2016 saw the big rate increases. So when the rates were reblended, it resulted in a significant reduction in the rates Plans J and C were not around at that time, so they were not affected by those large rate increases that occurred in 2015 and 2016.
So when you're referring to the reblending, you're talking about the net impact, what, since 2016, since 16 through now? Say some more about that, please.
So it was when the rates were reblended, it resulted in a reduction in those premiums for those Medicare, non-Medicare retirees. So they saw significant rate increases, and we can get you the exact dollar amounts if you want to see them, but it seems to me like Plan A members saw, wasn't it roughly a $200 reduction in their employee-only rate? And the Plan C, it was maybe $150 reduction. So, I mean, they were some pretty significant reductions for those two bands of employee-only coverage.
Yeah, and Commissioner Decken, as a reminder, this is for the retired individuals that have direct bill. They're not Medicare eligible yet. The discussion that we had in August about reblending them with the balance of the population to ensure that we got the rates more in line with what they used to
Okay. Now I'm clicking. Okay,
Right,
so it
very
had to do with that blending that we did, or that reblending. Okay, super. Thank you.
Yes, sir.
Yeah.
Any other questions or comments? Hearing none. Commission, appreciate all the work that has been done throughout this calendar year. Thank you for welcoming me with open arms throughout this year as well. Happy to be on here and wrap up our first year of business. As noted earlier, as soon as the open enrollment full summary report is done, that will be emailed around to the commission. We are looking at, once the state of the state and governor's budget release is confirmed, that's the day by which we have to have the annual report to the legislature. So we're going to work backwards from that calendar to make sure that that's circulated to the commission with plenty of time to review and provide feedback if necessary before we submit the official report. Commissioner Schmidt.
So, Mr. Chairman, any insight for us?
Tune in early January. It'll be a good one. With that, I would entertain a motion to adjourn. We have a motion. Is there a second? Second by Commissioner McGinn. All in favor, say aye.
Aye.
Any opposed? We are adjourned. Thank you.